All righty. All right. Well, thanks everyone for joining in. We're going to go ahead and get started now. My name is Valerie and I'm the PR lead for GOMI. Sorry about the little delay. We were just trying to work out some technical issues. First thing we're going to do is just go ahead and cover some ground rules. So we do ask that everyone keeps their mics muted throughout the presentation so there's no feedback. If you have any questions, drop them in the chat and they'll be answered at the end of the presentation. We would love to see your faces. So if you guys want to turn your cameras on, that would be great. And also if you could go ahead and just rename yourselves to put your school initials wherever you're from. We like to see that stuff as well. But without further ado, let's go ahead and get this going. So I'm gonna take it over to Katrina now.
Thank you, Val. Again, welcome everyone. My name is Katrina Stevens and I'm the webmaster of GOMI. And I'm super excited to help lead today's lecture. Just a quick reminder to go follow us on social media for all of our latest updates. And for just to let everyone know our mission again, we're here to create an educational platform where interested students and healthcare professionals can explore and interact with wilderness and emergency medicine. We strive to showcase the diverse spheres in which physicians and healthcare professionals can make an impact and inspire others to think abstractly about the ways in which we can utilize our careers in healthcare and medicine. And we strive to create an international community of wilderness medicine enthusiasts and experts committed to promoting a diverse and culturally competent environment. And a big thank you to our executive board members who make this all possible. And then here's a quick snapshot of our lineup. We have talks scheduled on a different subspecialty weekly featuring physicians and specialists at the top of their fields. And there are always more in the works. So stay tuned. There's lots to look forward to. And I hope you're able to attend as many talks as possible, interact with all the amazing people who have donated their time to teach us about the work they love. Today's speaker is Dr. Howard Donner with the amazing topic of expedition medicine. Dr. Howard Donner began his career working 8 years as a professional river and mountain guide. He is now renowned as one of the world's most experienced expedition physicians. Dr. Donner is co-author of the Field Guide to Wilderness Medicine. He's worked on numerous medical projects in the Himalayas, 3 seasons as a rescue doctor on Mount McKinley in Alaska for the National Park Service, an expedition physician on the first American ascent of Kinchinjunga.
Chimichanga.
Thank you. The world's 3rd largest peak, Olympic physician for the United States Whitewater team in Atlanta, and 5 years as a seasoned medical operations consultant for NASA. Dr. Donner has been featured in 2 award-winning Nova television documentaries, including The Deadly Ascent and Everest, the Death Zone. And without further ado, Dr. Donner, thank you for joining us today, and the stage is yours.
Hey, thank you. And I'd like to thank everybody on your end, including Shilpi, for inviting me and helping to coordinate this. So as much as I've been on Zoom a ton and I'm getting used to this kind of format, if you've ever seen me lecture, I really like group participation. So that's not possible today, but hopefully some of you will come to some of our conferences or some of the courses that we do, so you can get some more hands-on. I'm going to talk about expedition medicine. It's going to be sort of a potpourri of just ideas about expedition medicine and some considerations, and we'll see how far I get. And then I think Shilpi will probably give me the hook at some point, and we'll just stop and answer questions. So here we go. Need to get over to my other screen. And Shilpi, if you'd be kind enough to tell me if that's looking about right.
Looks good. We see your little pattern.
Good. All right. So I have a mental illness that requires that I show at least one videotape before every lecture. So here's yours for today.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät, das Überlebensradar.
Can you hear us? Can you? We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We're sinking.
What are you thinking about?
There it is. Everybody's laughing. I can hear it. Just amazing. This is the French Army knife. I hope that you all carry these in your packs. We're going to be talking about expedition medicine and how to get ready for an expedition. And it's funny when I give these lectures, and often at the end, there is an angry looking person at the podium with their arms crossed, the sort of body posture that's, well, you know, that talk was okay, but, and I'll go, hey, you have a question? They'll go, yeah, I'm kind of surprised that you didn't bring any ketamine. You didn't mention bringing fentanyl. You didn't mention bringing any propofol or any etomidate. And I'll go, are you an anesthesiologist? And they'll go, yeah, I'm an anesthesiologist. And I want you to get into the notion and into the sort of mindset that this is not the environment that we're working in. And as I like to say, you can't carry an entire hospital formulary on your back. And this on the right is probably the most sophisticated medical installation I've ever worked at in the mountains. And that was the rescue medical tent on Denali at 14,000 feet. And, you know, most of the time you're working out of a backpack and or out of a few big rocket boxes or plastic Tupperware. So you have to get used to not bringing everything that you are learning now for the medical students and for the doctors listening that you use in your daily practice. So this is probably too much. So how much to bring? Well, I wanted to get people kind of cold, and I don't have time really to ramble and tell war stories. This was a rescue we did on Denali a number of years ago. And this guy took a huge screamer, a big fall off the Messner couloir, and he had a broken neck. We've got a SAM splint on him there, got him on a backboard. He had a hemopneumothorax. We put in a chest tube. He was hypothermic and a serious back fracture. We flew him off the mountain in our Llama. This is a very capable high altitude helicopter called a Llama. And since we used it on Denali, of course, we called it the Denali Llama. And here we are interfacing with the PJs who picked us up in a Black Hawk at 7,000 feet. And we flew into Anchorage. I had an anesthesiologist, a radiologist come to one of my lectures. He goes, I took care of that guy. I've got the pictures from that particular patient. So here's his hemopneumo, and sadly, this is his thoracic spine, major step-off fracture. He's obviously paraplegic, but lived through this. And one of the other rescuers went to visit him in Sapporo, Japan, and he's doing well. As in my introduction, I worked for NASA only as a consultant for many years. It wasn't full-time, but we worked on building the medical system for both the space station and the shuttle. And this was an original prototype for the space station, the so-called ALS pack. It was a series of packs like this. The ALS pack was the advanced life support pack. And again, it would be fun to talk about this kit. A lot of what I talk about today will be similar to the stuff you'd find on the space station, which is basically just another expedition, just happens to be in space. And you can buy one of these after my talk, I think for $18 million if you prefer. But we'll talk about how to jerry-rig this stuff. I wish that my pack was this nicely labeled, but it never seems to be. This was the SOMS kit, the Shuttle Orbiter Medical System kit. Everything at NASA is an acronym. There were two of these, and pretty much everything that was taken into space on Space Shuttle was contained in two of these SOMS kits. This is working for the Himalayan Rescue Association. In this time, it was in Farache, which some of you have been to. It's about a day and a half or 2 days from Everest Base Camp. Well-meaning expeditions from all over the world dump their medicines there. It's kind of funny, even if you bring some kind of a PDR or some kind of a medical reference, there's just all sorts of stuff all over the world that you've probably never used. For example, I had never in my practice used streptomagma, but maybe some of you have. So how much to bring? You know, it's always the question, like, what should I bring? How much to bring? What's too much? Again, we're not in this kind of environment. We're talking about stuff you can stuff into a little pack. And it always bothers me when I am, living my life and one of my friends or colleagues will call me and say, hey, by the way, what should I put in my medical kit? I'm going to stop for 1 sec. Shilpi, if you can hear this, since I'm just talking into a blank screen, I just want to make sure that the audio and everything's going okay.
Yep, you sound great. This is awesome.
Good. So I always say, what to bring in a kit, what should I bring in my kit? Well, I can never answer that because it really depends on what you're doing. Are you going on a sailboat where you have a ton of room for your medical gear? On a river trip, I worked many years as a river guide. You can bring a lot of medical gear. You carrying this stuff on your back, or you on an expedition? So it's really hard. And what is the environment? Are you going into the Arctic? Are you going into the tropics? The stuff you bring for high altitude or for cold or for heat, it's going to be very different. If you're going out on a ski trip, the demographic of your group makes a difference. Are you taking care of a bunch of seniors? I used to look at a picture like this and go, look, old people. And now I'm an old person. It's really weird. For you young people, know that it'll happen to you. I don't know how many of you know Dr. Julio Pena, but he was telling me about an expedition that he went on. And he said, yeah, here's a picture from my expedition. And it looked pretty cool until I saw the actual larger version of this. And it looks like this. So he was deep into the woods of Central Park. And the reason I show this picture, Julio, I kid. The reason I show this picture is because something that nobody talks about is your distance from definitive care. So in the modern era, you might be on Mont Blanc and you might be in the most beautiful alpine environment going, oh man, I'm in the middle of the wilderness. Look at me, I'm a doctor on this, hoot route trip around Mont Blanc or something. But you are a cell phone call away from having a helicopter pick you up. And, literally 20 minutes later in most weather conditions. So that's very different than being, on a 1 week into a Brooks Range trip in Alaska without a sat phone or any communication, and in bad weather where you may truly have to take care of somebody for a week or 2 or 3 on an Arctic expedition or whatever. So the distance from definitive care is big. Now, I know that you're not all medical students today, but for the medical students, I have a secret for you. Doctors lie. So your attendings are lying to you because they will often give you the most elegant way of treating a specific entity. But in truth, when you're in practice long enough, you don't always do everything that you teach. And in fact, that book that we used when I was in medical school to learn how to do a physical examination, if you were to actually do that physical examination on patients in the real world, you would see 2 patients per day. So you learn to abbreviate. So I don't carry all this stuff on an expedition. And often if you look in my pack on any given day, I might just have some duct tape and a SAM splint and some ibuprofen and maybe an ACE wrap. So the point is that we talk about all this stuff, and some of this is optimal for a larger expedition, but for a smaller trip, you may just carry a handful of things in your fanny pack. I should say butt pack, because I guess you can't say fanny pack in Britain. I always tell people when I'm going on a trip to bring their own stuff. And I either tell them or make a list of what I want them to bring. For example, bring your own sunscreen, bring your own lip goo, bring your own blister stuff, bring your own ibuprofen, whatever it is. And that's because partly because I'm lazy, and every time somebody's got, a little boo-boo and you have to break into the expedition kit, it plays havoc with the kit because you're rummaging through the kit all the time looking for stuff. So I try to make sure that people on my trips, especially on a bigger trip, have their own little first aid kit. So we're not using the expedition kit just for handing out Band-Aids and ibuprofen and stuff, but you'll make your own minds up about that. Sadly, I only have, I think Shilpi told me I have 4 hours for this talk. So I have to kind of cut my my stories short a little bit. I'm just kidding, Shilpi. And this was a shot from the Himalayan Rescue Association in Manong early in my career. And I'll tell this one story right now because it's funny. we had an interpreter that was a Nepali English interpreter. I speak a little Nepali, but not enough. And then we were in this town called Manang where they spoke this dialect. So we had a Nepali Manang Ba, the language is Manang Ba interpreter. And then this patient in the foreground is Tibetan. So we had a third interpreter that went from Manang Ba to Tibetan. And I would say something like, Asuk, the name of our interpreter, ask him if it hurts when he urinates. And Asuk would ask, and then it would go to the next interpreter to the next, and then the next interpreter, and the family was there. And pretty soon all the interpreters are arguing, and the family is gesticulating, and people are shaking their heads and talking. And I would finally go, Asuk. He'd go, yes, Dr. Saab. I'd go, what are they saying? And he would go, no. So clearly something lost in translation. Moving on. This is Percocet, a famous expedition doctor named Gil Roberts, who was the doctor on the first successful American Everest expedition in 1963 with Willie Unsolt and Barry Bishop and Lute Gerstedt and Tom Hornbein, those guys. He said, when I was young and impressionable, like some of the med students listening today, it's heroic fantasy. Those were his words, heroic fantasy, to imagine that you can treat everything that ails people when you're an expedition doctor. You're going to have to stand there sometimes with your hands in your pocket and watch people die. And sadly, it's true. And, you know, you guys are all learning that if you can't fix it, somebody can. And if they can't fix it at your clinic, you send them out. And if the hospital can't fix it, they send them to a tertiary care center. And somebody can fix it, surely. But not true in wilderness medicine. And Gil Roberts really impressed me with the fact that you should always be prepared to alleviate pain. That's something you can always do. So I'm not going to talk about pain meds here. I'll just tell you, you need to bring pain meds. I put designer NSAID because if you go to Costco and buy a gumball machine full of ibuprofen, that's a lot of medicine. If you're giving people industrial doses of ibuprofen and they need to be on it for their 5-day hike out or whatever. So, you know, they make NSAIDs now, things like meloxicam that are longer acting. I carry both usually. As far as your actual, you know, analgesic of choice, I'm not going to really speak to that. Some people like morphine. That's a special forces auto injector of MS. Some people swear by ketamine, and if they could bring one agent into the wilderness, it would be ketamine. Some people love Dilaudid. Some people would just bring fentanyl. There are pros and cons to all of these, so you'll make up your own minds. This is a hard part of the talk. You guys are taking microbiology and infectious disease classes, and obviously there's a bunch of doctors out there as well that are practicing in all sorts of fields. You know, what antibiotics to bring? And it's not an easy answer. I can tell you that in my experience, and this is not anything that will surprise you, there are 3 entities that are really common in the wilderness, and that's respiratory infections, upper and lower tract respiratory infections, GI, mostly in the form of diarrhea, and then soft tissue infections, wound infections and abscesses and that kind of thing. So you want to make sure, and then some other stuff we'll talk about, but you want to make sure you can cover for that. Now, this is not a lecture on ID. Everybody's got different ideas about what to bring, what works, etc. I'll tell you though that you want drugs that typically kind of follow a pattern. And one of those might be a drug like azithromycin, in that most people, and there are some issues with azithromycin, as you know, some certainly precautionary cardiac facets of azithromycin. But I like azithromycin, assuming it doesn't kill the person you give it to, because most people tolerate it well. So it has a low side effect profile. It doesn't have amoxicillin in it like something like Augmentin might. So most people can tolerate it and are not allergic to it. But especially it's got a really easy dosing regimen. And if you're like me, I always think it's funny when I go to the doctor and the doctor goes, okay, here's a medicine, just take it 3 times a day or 4 times a day. I laugh internally because I know I'm lucky if I take a medicine twice a day. On an expedition, it's even worse. So what a great thing to have a medicine that you can just take a few, you know, just a daily dose just for a few days, and essentially end up with a serum concentration that will last for a normal course. Also, if you're carrying this stuff in your pocket, i.e. on your pack, better to carry fewer pills than more. But again, oh, and it has redundant uses. So azithromycin actually has pretty good tissue penetration and can be used for many things other than just respiratory. Some people argue third generation and fourth generation fluoroquinolones, things like Levaquin, would be the way to go. For diarrhea, a lot of people just still carry good old-fashioned second generation fluoroquinolones like Cipro. There are precautions with all these medicines, and with Cipro, you know, the whole specter of potential tendon rupture, etc. We now live under the specter of methicillin resistance. It's not just a problem in your hospitals, but I've seen a number of cases of MRSA in wounds associated with wilderness travel, or at least during wilderness travel. They might have been infected prior to entering the wilderness, but I've seen wounds infected and abscesses on river trips that turned out to be MRSA. So you need to carry something for that. And in this last picture, I guess I went back too far here, but whatever you like to carry for MRSA, that might be something as simple as, it's coming, wait for it, something like Septra. Now, you guys are taking long, semester-long courses in tropical medicine. And you can read Manson's Tropical Disease and do a fellowship in tropical medicine, or you can just remember that somewhere at the bottom of your kit, not a bad idea to bring some doxycycline. I had an infectious disease guy once at a lecture I gave, and he was giving me that kind of look at the end of my lecture, standing at the podium, and I said, "Hey, what's up?" He goes, "Yeah, you were talking about doxycycline." And I said, "Yeah." And he said, "Doxycycline really isn't first line for almost anything." And I said, "Yeah." And he goes, "But interestingly, it's second line for almost everything." And it's interesting. I would just get used to having doxycycline, especially on a longer trip somewhere, that's more exotic into the developing world, for treating things like rickettsia and mycoplasma and psittacosis, and it treats spirochetes and leptospirosis and typhus and Lyme disease, and on and on and on and on. So it's not a bad idea to have some of that in the bottom of your kit. Don't forget that this stuff costs money. I got into the habit in my career of stealing medicine out of sample cabinets. When I worked in Telluride and I was going on expeditions, we had a family practice there as well as an emergency room. So, just steal it. But when you're buying meds for people going on expeditions, this stuff gets really expensive. So just be cognizant. And I think most of you would be, but don't forget generics, etc. I don't really have time to do a talk on GI. I can tell you, we already talked about using something like Cipro. There are some newer drugs that are coming down the pike, things like rifaximin, which is a non-absorbing treatment for non-invasive dysenteric infections. There are newer drugs now for Giardia and other protozoal infections. One of my favorites, and it's not that new, is tinidazole. It's like metronidazole, which is Flagyl, but you just dose it 2 days in a row instead of 7 days, and you kind of sleep through your side effects if you take it after dinner. And the efficacy seems to be as good or better than metronidazole. So when your friends, family, and patients have Giardia, instead of thinking metronidazole, consider tinidazole. Talk to your attendings about that. It used to be hard to get in the US. You couldn't. But in fact, I used to have an underground practice when I'd come back from the Himalayas and people go, "Did you get the stuff?" And I would usually come back with some tinidazole because it's so much better. But now you can get it here. And often pharmacies don't carry it, but it's easy to have them order it for you. Imodium is sort of cork in a box, and not a bad idea. There's some mild contraindications I won't go into now, but if you're ever on a bus ride from Kathmandu to Pokhara and you have explosive watery diarrhea every few minutes, you're going to wish you had some of this. I'm sorry we're going so fast on all of these topics, but it's basically a 45-minute talk on all of medical school, so I'm going to keep moving. This is a meter dose inhaler. This is a spinhaler, because carrying a meter dose inhaler like this with albuterol on Denali, they used to freeze, but not a bad idea to carry this. A lot of doctors treat coughs with cough medicines. I find that especially at altitude on expeditions, often, not always, but often coughs are associated with a reactive airway component, bronchoconstriction. And rather than giving people cough medicine, you can try a bronchodilator. And if they're at altitude, they'll be happy. And there are actually some indications for actually using this for high altitude pulmonary edema now, which I don't have time to talk about, but maybe next year I'll come back and talk about altitude. So I'll talk about one thing here because of time, and that is this lowly product here, Afrin, over the counter. This is oxymetazoline. It's a topical nasal vasoconstrictor, and that's because nosebleeds are common in the wilderness. Back in the olden days, we used to pack noses, but some ER doctors a few decades ago invented rhino rockets, and now there are a whole host of these kinds of Miracell foam pledgets and Miracell foam tampon-like things that you can put into the nose rather than packing the nose. And packing the nose is just really hard to do. The only people that can do that are otolaryngologists. I used to pack noses in med school and in residency, and the patient would sneeze and they go, and the whole thing would shoot out because it's really hard to get back in there. These things are a lot easier to put in. But you usually don't need to use any of these things. Oh, why would I put bacon? There was this tradition of using pork to treat epistaxis, but the technique fell into disuse because it was fraught with all sorts of bacterial and parasitic complications. And now we have these newer synthetic hemostatic agents. So I wouldn't use bacon or salt pork. I put this in just because it was a wilderness medicine talk and I wanted to look at a picture of bacon. So usually you don't even need to pack the nose. The reason that I showed the picture of Afrin was most people would come to you and, even in the ER, they would come in and they've been at home, their nose bleeds, they sit for 5 minutes, they run around, they sit, they run around, they come into the emergency room. All you need to do is just have them sit down, not lie down because then their head's dependent, not stand up because then they're running around. Just sit comfortably, get rid of all the clot, have them blow all that goo out of there, that jelly-like stuff. Start with a nice, fresh, clean nose, spray a bunch of Afrin in their oxymetazoline, and then just put pressure on their nose. And admittedly, you can't always put the pressure where the bleed is, especially if it's higher up, but just sitting quietly with the vasoconstrictor in their nose. And then this is the part they don't teach you in otolaryngology residency, and that is you have them look at their wristwatch because there's some kind of time dilation when your nose is bleeding. And you have to say, if they have a wristwatch, I want you to sit here until the big hand is right here and show them 20 minutes. Otherwise, they'll sit for 5 minutes and think that's 20. And 93% of the time, I made that number up, so do not quote me, the bleeding stops without having to pack it at all. They make these things. I have one of these, which I've brought into various expeditions. They're just really lightweight plastic little otoscopes and a lot lighter weight than the metal ones you're using in your departments. Don't worry about the Tessalon pearls. That was for another talk, but I threw this in to remind you to take prednisone. And I always forget why. Just you're going to be on a trip where you need prednisone. Somebody comes to you on day whatever. Hey, I've run out of my meter dose inhaler. I'm wondering if you have, you've got some prednisone. So having a steroid can be really helpful. You've got poison oak all over your genitals. You've got prednisone. You're on a dive trip and somebody's got some horrific marine exanthem. You've got prednisone. It's just really good. You're at altitude and you've got prednisone. Yes, the preferred drug for high altitude cerebral edema is dexamethasone. But if all I had was prednisone, you better believe I would give it or take it. Cough medicines, I don't use too much. As you know, the efficacy is not great. When people get kind of, dry throat, so-called altitude throat, kumbu cough, I have them take just cough drops, kind of wet their whistle. The problem with Ricola is you have to put up with this lady, Ricola. But that works pretty well. Now I want to talk about the part of the talk that I never know where to put it in, and it's why you shouldn't carry white powder across customs in a Ziploc bag. I was on a trip in Patagonia. This is a HIPAA violation because there's her name. I was on a trip in Patagonia a number of years ago, and this nurse that was on the trip reaches into her backpack and pulls this out and takes a pinch. And I said, "What the hell is that?" And she said, it's ibuprofen. And I said, oh, can I take a picture of that? And she goes, sure. Why? And I said, can't explain. But anyway, I can't tell you how to get stuff across customs. I promise you. I can only tell you what I've done. And that doesn't mean it will work for you. So a couple things. Number one, don't carry white powder in a Ziploc bag across customs. So I've found that if your meds are better organized and they're nicely labeled and they're in little tiny vials or plastic vials or little Ziploc bags and well labeled, that makes custom officials more comfortable than this kind of thing. Number two is carry a prescription for all the meds you're bringing. So even though you got the meds from your good friend who wrote scripts for you, bring the prescriptions. Take 2 every 4 to 6 hours PRN for severe pain, and that's on your whatever it is, your Vicodin, rather than just having the vials. Number three is bring at least a photocopy of your medical license, which works better than saying to the customs officials, no, dude, really, I'm a doctor. And then lastly, I don't really do this. Remember I said doctors lie. So I'd be lying to say I've done this many times, but I've done it at least twice. I've gone on expeditions and I've gone to Office Depot and gotten, like a certificate looking thing, like a diploma or something, anything with filigree on it or that's embossed, and then write a letter for yourself. By way of introduction, Dr. Howard Donner will be the medical officer on the 2021 Expedition 2, and then just have your friends or just scribble some signatures that are illegible. And when you show it to customs officials, you just hand it to them and they'll go, very good, sir. And you're on your way. Eyeballs, not going to talk a lot about. And Shilpi, if you're there, can you tell me how much time we have?
You are at, it's 5:36 right now. It's like 15 more minutes.
Okay. Wow. I thought I had 3 more hours.
It's like 2 hours and 15 minutes for those of us that want to stick around.
Okay, we'll give people a break after an hour and a half. This is Ama de Blanc. It's a beautiful mountain a couple days from Everest Base Camp. And the snow usually goes up to where those rock bands are up on the mountain. And there was this unseasonable snow, and we had all sorts of porters crawling around for days in the snow. I saw more frostbite than I've ever seen. I think, well, maybe not. I've seen more on Denali, but we saw at least 20 or 30 cases of really severe frostbite. Had to fly these guys out. But the thing that was interesting is these guys didn't bring sunglasses because dirt and rock does not reflect much UV, whereas snow does, more than 90%. So we saw, probably 50 or 60 cases of really bad snow blindness, which is UV photokeratitis. And that's what these guys look like. Now, I don't have time to talk about eyeballs, so I'm not going to, but one of the themes in this talk is, and one of the beauties of wilderness medicine and expedition medicine is that you can improvise. And I'd been on and these guys were really photophobic. So we talked to the local guest houses and said, hey, we've got like 45 porters that need to spend the night at your place because we didn't have room in our clinic. And they're like, no way, we don't have room for that. It'll destroy our business. We can't do that. And these guys were so photophobic, they just could not go out in the bright light after the storm was over. So after we treated them, as like, we don't have 45 pairs of sunglasses, but I'd been on an expedition where I can't explain why I put an emergency space blanket over my head and I realized you could see through it. And I remembered that. So I took an emergency space blanket and just cut it up. And we made all of these improvised sunglasses with duct tape around the back. And Namka, who used to run the Himalayan Rescue Association in Feriche, thought it was the funniest thing he'd ever seen. This is him. He made a sign that said closed due to snow blindness. And for weeks, we had trekkers coming up to our clinic going, excuse me, doctor? Yeah. What was with all those sort of disco porters coming down the hill with those silver things, So anyway, it's fun. You can improvise. And there's all sorts of stuff. If you lose a sunglass, when I was in Patagonia last year, I think it was the last trip I did before COVID, somebody broke their sunglass just like this. And I had them fashion a pair of slits just using duct tape, like the Inuit used to do, still do in Alaska, slit sunglasses to reduce the amount of UV. If you even lose your refractive lenses, you can make a pinhole camera by taking duct tape and just poking a bunch of holes in it. And believe it or not, using the pinhole effect that you learned about in pre-med physics, it'll help you to refract. The problem is, I told Shilpi about this, and she was on a trip and she tried this, and she took a safety pin and poked all these holes in, but she didn't take the sunglasses off the patient first. And Shilpi, I believe that's settling out of court now, as I think you said in your text. I was on a trip. I think I was going to Thailand, and the flight attendant came by, and this was the little Twizzler stick, and it had these little pinholes on it to use as improvised reading glasses. And I got so excited. I think the flight attendant thought that there was something wrong with me, but when I got off the plane, she had this giant bag filled with these, and I had about 500 of them that I gave away to friends, and I still have about 20 of them, because you can use these, throw them in your pack. Now, you might say, well, if these work so well, why don't people just use these for refractive lenses? And it's because they attenuate quite a bit of the visible light, so they don't work well in dim light. One last thing, multimedia. If you are trying to do a procedure and you're used to having your loop in the emergency room, which is a little microscope that you can use to look at a wound with for fine suturing or to look for corneal abrasions, it's really hard to see. But there's probably somebody like me with old man glasses, and there's probably other people that have them. And believe it or not, it's arithmetic. So if you put a 1.5 on top of a 1.5, you've got a +3. And I always bring extra sunglasses. And if you know any ophthalmologists, I've got a good friend that when I go see him, I literally distract his receptionist and take these out of the basket at the front there. So after they dilate your eyes, they give you these things. And that way I've always got spare sunglasses in my pack, especially on an expedition. And you put them in these things that they used to carry, something called Flim or Film. It's something FILM that they used to take pictures with. And you can put them in these little canisters. I kid. Okay. Wow, we're running out of time, but I'm gonna talk a little bit about CNS. We could do a whole talk on sort of neurological and psychiatric aspects of foreign travel. A few things you might want to bring. I learned as a river guide that on the second day of a trip, there was sometimes somebody sitting on a raft going, and I'd go, what's wrong? And they'd go, headache. And I'd say, drink much coffee? And they go, yeah. I go, how much usually? And they go, I don't know, maybe 14, 15 cups a day. And that's caffeine withdrawal. And sometimes guides would literally on a 1-week river trip buy decaffeinated coffee. So you have two choices. You can cold turkey the person there on the river trip, or if you've got NoDoz, which is caffeine citrate or some form of this, you can give them caffeine and ibuprofen. And if you're a river guide, at the end of the trip, you'll get a big tip. The Special Forces uses some of these newer agents like Provigil and Nuvigil. They tend to give you the alertness of coffee without the jitteriness. This is a good thing if you are doing rescue. And I can tell you on many all-night rescues, you're in the emergency room, it's 3 o'clock in the morning, you brew up, you go get some nasty swag coffee. But if you're on a rescue, you're not going to stop and brew up. So what do? I always carried NoDoz or something like it so that I wouldn't walk off a trail at 4 a.m. after being on a rescue all night. The Special Forces uses Provigil and Nuvigil, but they have a very bad side effect, and that is something called bankruptcy. Not a bad idea to carry some kind of sedative. I'm not here to tell you what kind of sedative, just something to treat an entity that I refer to as benzopenia. And if you spend enough time in the wilderness, you will have people that go bonkers, and not a bad idea to have something to chill them out a bit during their evacuation or during a prolonged stay in a snow cave, in a snowstorm. Trust me, I've been there. I think we're going to have to start winding down. Cardiovascular, I'm not going to talk a lot about. I'll mention that back in the olden days, there wasn't much you could do. We're now entering, for all you youngins out there, we're entering this era where you can actually monitor patients on trip. Most of you, I shouldn't say most of you, some of you know about this. It's an AliveCor heart monitor. It gives you a lead 1 ECG. you can actually, most people don't know this, but you can choose from 2 other placements and get a lead 2 ECG using the left knee, et cetera, even an anterior precordial lead. So, now we can monitor patients, and now we have these small AEDs as well, so we can defibrillate patients. So maybe instead of just bringing some aspirin into the wilderness, maybe we should bring a whole bunch of, ACLS drugs. Well, in my day, we didn't do that. And one of the problems is you have to carry this thing, which is very heavy. And that's the crash cart. But one thing you should always bring into the backcountry, always, 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 is some aspirin. And Shilpi asked me not to mention trade names, but this is one case where I'm going to. I really like Shopko aspirin. Shopko aspirin. I find stethoscopes aren't that helpful. Sometimes at altitude, nice to be able to listen to a patient. There's some lightweight stethoscopes. This is a backcountry stethoscope that's just sort of got one earpiece. There are all sorts of small things you can bring, including this. I've got one of these. It's a bag valve mask that's really small, works really well. It's a BVM, comes in a little tiny kit. The problem is good luck ever getting it back. Not going to talk about airways right now because we don't have time. Chest tubes, all sorts of stuff. One thing I might leave you with is another thing that we really didn't use in my practice. And Shilpi, you might be laughing because I'm assuming people don't know about these things, but a lot of my colleagues are still surprised when I talk about these. Maybe the med students all know about these, but the Butterfly IQ is basically a fairly high fidelity ultrasonic transducer that you can hook into your smartphone. And nowadays you can actually be taking ultrasound into the field, and you can do extended focused assessments in trauma. This is a picture of a control patient on the left with no comet tails, and on the right, an ultrasound image of comet tails, which show up in patients with pulmonary edema, in this case, high altitude pulmonary edema. So a lot of new stuff going on in wilderness medicine with technology. I think the last thing I'll talk about, and then we're just going to randomly stop because this talk could go on for hours, is GYN. When I went to work at NASA, I was helping to develop the medical system for the space shuttle. And when I went to Kanchenjunga, I jokingly said that it was chimichanga because no one can ever pronounce Kanchenjunga. It's not chimichanga, it's Kanchenjunga. I was just literally, the research I did was sitting in a chair just going, I wonder what I should bring. Because there weren't books in those days on expedition medicine. I mean, there were, but they were not the best, and none in the US. And I thought, I've got a bunch of female support truckers. And the thing that scares me about women in the wilderness, I mean, there's one thing that scares me about women that doesn't scare me about men, and that is complications of first trimester pregnancy. And I thought, how am I going to make that diagnosis on a long trip? So, I just ended up bringing in urine beta HCG kits. And when I went to NASA, I said, I don't see any beta HCG kits in your, on space station or on shuttle. And they go, yeah, we don't fly them. And I said, why not? And they said, because all of our female crew persons are required to get tested 2 days before they fly. And I said, and they said, oh yeah, well, and they are required to abstain from sex for 2 weeks prior to any flight. And I said, you need to get these. And so now they fly them. So I'm always happy when I see the space station go over and I know that the beta urine HCG kit that I recommended is in there. In fact, I got this one, I think, at the dollar store, and the woman that I was with said, why did you just buy 5 urine pregnancy kits? And I said, because they're $1. The last thing I'll mention, because we're just going to stop at the end of this little section on women, is I've seen a lot of yeast infections, vaginal yeast infections. I think it's just because women on trips end up with diarrhea. And when they have diarrhea, they take antibiotics. And when they take antibiotics, they often end up, I mean, it's not this simple, but my conjecture is that that's why you get a lot of yeast, because a lot of women on potent antibiotics for diarrhea. But at any rate, I've seen it a lot in the wilderness. And yes, you can bring goo, but you have to carry it. It's heavy, takes up space. So I usually just use diflucan. I've had women come up to me and say, I like diflucan. Yes, it works. But for the first day or two till the diflucan kicks in, I have to deal with the inflammation. So you can just pull some topical steroid out of your topical kit, something like Kenalog, and give them that for a day or two until the diflucan kicks in. Here's a really fun story that I wish I could tell, but I don't have time for because Shilpi is going crazy because I'm continuing to talk. And I just showed this picture because at NASA, I understand that there are still reporters that call them and say, what the hell is going on Space Shuttle and Space Station now? We see that you're carrying urine pregnancy kits, and they have to explain why they're carrying urine pregnancy kits. Anyway, I could go on and on, Shilpi, but I think what I should do is stop so people have a chance to answer questions.
Dr. Jotter, that was great. We will definitely need to have you back so we can hear all your war stories, because I know we all want to hear them. But yeah, I want to turn it over to Val and Katrina, who we have a lot of questions from everybody. So I know they don't want to hear me talk. They want to hear you talk. So Val and Katrina are going to go through the questions so we can get some answers. And thank you so much. That was really an awesome talk, like truly very entertaining.
Well, thank you. Thank you. It's funny. I always tell people when I'm invited to give that talk, they go, we've given you 35 minutes. And I go, I'm going to need more than that. And they go, no, we don't want people to get bored. And I always say, I make half the stuff I talk about up, but I promise you they won't get bored.
So the number one takeaway, doctors lie, right?
Doctors do lie. And I don't mean any disrespect there. I just mean that when you are standing at a podium, you say stuff that isn't true. Like this is how it's done when it's not done that way. I don't know if you know this, but I'm a flight instructor these days, and it's the same thing. I teach my students things that I don't do, and I always think about that, same as an attending. Anyway, I could go on about that, but I won't. And I see Julio laughing over there, so I'm going to shut up and let people ask questions.
All right, Ellen, Katrina, it's all you. Thank you, Dr. Donner.
Sure.
Thank you, Dr. Donner. That was great. And I'm super relieved to find out that Shilpi's trial finally got settled in court. That's good to know. We've all been talking about that on the board, honestly. All right, so we're going to go ahead and get started with some general questions, and we'll go into some more specifics about your actual talk. So a few that trickled in were just obviously, as a wilderness expedition physician, you obviously have to love outdoors, being in nature, kind of having this remote, austere environment. But what would you say is the most important thing when considering whether to decide on making this an actual career specialty or something that you pursue in the long run?
I think I understand your question, but do you want me to talk about how one might prepare for that, or do you mean personality? Like what kind of substrate somebody should have to be wanting to do this?
So we actually have both questions, which is how would you prepare to go into this specialty, and also the personality. So whichever one.
I starting with personality, I would say, your IQ is not going to be the bottleneck. It's going to be common sense. And I'm sure everybody in this talk knows doctors that are super smart, what you might call book smart. And I find that book smart doctors don't do as well as doctors that may have a lesser knowledge base, but a very creative and common sense approach to things. So you look at a problem and you go, wow, I've never seen this. I don't know what to do really. It's not in the textbook, but I'm going to improvise. And so creativity, flexibility, kind of a common sense approach. I have seen expedition doctors from every walk of life. When I was on Everest on that Nova film, the Canadian doctor is an oncologist, heme-onc guy. So, you could come from any specialty, but I think it's easier if you come from a specialty where your patients won't hate you when you leave. And so family doctors, patients, where were you? You were gone for 2 months. I hate you, emergency medicine works pretty well in that regard. Anesthesiology works pretty well in that regard. And those aren't the only two, but just think about that. Professions where you can get away without having to suffer extreme guilt. I know Julio's smiling because he knows the guilt thing. Then as far as training goes, primary care training is basically what you need. But if you're not emergency medicine trained, let's say you're a really good primary care internist and you're used to taking care of people, there are some skills, and I wrote a chapter and I made a list of these things, but I can't just rattle them off, but things especially like suturing and dealing with orthopedic injuries, that maybe as a primary care internist, for example, you might not do a lot of suturing. Maybe you send those patients to the acute care center or to the ED. Those are the kinds of things you're going to need to know how to splint orthopedic injuries, how to reduce dislocations, how to do some very basic procedures. So I would brush up on basic primary care, kind of acute care center style procedures before I'd venture out on an expedition, because you will have to staple or glue or suture inevitably.
All right. That
Oh,
makes
and
sense.
then I'm sorry. It's Val. Is it Val?
Yes.
Val, I'm sorry to interrupt you. But as far as, well, no, I'll stop there. But I'm wondering if there was another part to that question about how one gets into it. But I don't want to talk through all my time.
You can totally go for it, because that's definitely a question as well.
And I don't have an answer, so it's easy. For years, people would say, I want to do wilderness medicine, and how do I get into it? I got into it in a time when not that many people were doing it. So I called myself an expert, and people thought that I was. I truly believe that if I was trying to get into wilderness medicine now, I wouldn't be able to, because I don't have a super specialty. My specialty is being able to BS about anything, but I don't really, I'm not the world's expert on altitude or cold or anything else. Nowadays, the people that are making names for themselves have a super, focused specialty. But that's not my answer. My answer is, I think that wilderness medicine is such a big topic that when people say, and I'm not making fun of anybody, but I'm going to pretend like I'm making fun of them by mimicking them, they'll go, "Hi, I want to get into wilderness medicine. What should I do?" It's such a big field that I've realized that doesn't help you focus, because what does that mean? Does that mean you want to do snake bite, tox, anti venom, molecular biology, or does that mean you want to study high altitude physiology, or does that mean you want to work in some war-torn country doing primary care, or does that mean you want to do rescue? What does that even mean? So I think the best way to get into wilderness medicine is to actually, this is my new age answer, is to actually sort of imagine exactly what you want to do, at least initially. I don't mean for the rest of your life. I don't mean because you want to go study altitude, you have to do that for the next 50 years. But I mean, just say, I think I want to do altitude research. And then it narrows it down. And there are, 5 places in the US that do altitude research. And you pester somebody with about 1,000 emails until it's easier for them to let you come work with them than to keep telling you no. And you tell them, I don't want any money, blah, blah, blah. That's how I got into NASA. I called them and they said, "We don't take residents." I was a resident at the time. And they go, we don't take residents except for aerospace residents. And I said, "I want to work there." And they go, "We don't want you." And I kept calling. The guy said, "You sound pathetic. I'm going to put you in touch with the medical director of the space station at the time." And I said, "Look, you don't have to pay me. I'm just going to come work there for a month and blah, blah, blah." So I worked there for a month. They realized that wilderness medicine was a field that they were lacking in. And they hired me to continue doing consulting for them. So, kind of push your way into things. And so don't think wilderness medicine, think altitude, think rescue medicine, think tropical medicine, and then find the people that are doing it and go bother them.
I love that. That's great. And I'm going to put a shameless plug in here, is that our website actually does divide a lot of those topics into different categories that you guys can go watch different videos on if you're struggling to figure out what kind of wilderness medicine you want to be doing. Shameless plug.
Great, perfect.
Anyways, next question. One of the questions that was asked during your talk was, once you're, going to a different country and you're doing this expedition with other people, how do you get registered in that country to practice medicine there? And does that affect your, registration, your medical insurance, stuff like that?
This is not the answer you want. And for the attendings in the audience, just plug your ears and sing. One of the nice things about wilderness medicine for me has been that if you practice wilderness medicine, you will never accrue enough equity. It's another word for money, to worry about getting sued. So I always figured if somebody ever tries to sue me, I'll say, fine, you can, I have a pretty nice mountain bike and I have about 4 sets of skis and some pretty nice backpacks and some climbing gear. You can take it. I still drive a Suzuki. I still rent my house. And so, you know, it's one of the sort of self-equalizing parts of wilderness medicine. You'll never make any money so that nobody can sue you. But I would let your professor, I mean, they can sue you, but all they're going to get is a mountain bike and some old skis. But I would let your attendings address the formalities of that question, because yes, I just wrote a chapter in an emergency medicine. I say just, it was before COVID, so it's been a while, but a chapter in an emergency medicine book called Is There a Doctor on Board? Medical Emergencies at 40,000 Feet. And it addresses that when you're practicing medicine, even on an airplane, you know, whose jurisdiction is it? Is the carrier, the airplane? Is it the country you're flying over? Are you licensed to practice medicine as you're flying over, you know, whatever, Pakistan? So, and the answer is no, but the good news is because of Good Samaritan Acts, and there are very strong Good Samaritan laws worldwide. I shouldn't say worldwide. There are some places where it breaks down, but generally speaking, certainly in the US and most of the world, if you're doing the right thing and there's no evidence of gross negligence and you're not being compensated, it's really hard to sue you. You have to use standard of care. So you can't just be in the wilderness and go, yeah, you know, I'm gonna, you know, rug yak poop on this wound because I saw somebody doing that. Standard of care medicine, no negligence, and you're not being compensated, it's really hard to sue you. But one could argue that if you're given room and board working for the Himalayan Rescue Association, for example, that's a form of compensation. And an attorney could argue that. But you're going to have expert witnesses and you're going to have organizations that you're working for, like Médecins Sans Frontières or the Himalayan Rescue Association or the Park Service or whoever it is, with expert witnesses arguing in your case in front of a jury. So don't imagine yourself in this totally hostile legal environment. You're going to have people that are arguing for you that are going to try to protect you. Right. But I want your attendings in your department to talk about the formalities of registering in those countries. I'm the worst person to ask because I was always in my career kind of a cowboy in that way.
I love that. That's what a lot of EM physicians are known as, right? The cowboys. All right, so we have time for a few more questions. These are a little bit more specific from your talk, but they're kind of interesting. So someone did ask, and you mentioned benzopia, I want to say it was. So they were asking, are you referring to folks running out of their own supply of benzos, or they're stressed naturally being in that austere environment?
Yeah, so benzopenia, meaning low in benzodiazepine blood levels. Benzopenia, like anemia, but with benzos. Yeah, just that the wilderness environment, you know, there's this scene in Buckaroo Banzai. It's an older movie now, but the guy's a brain surgeon and a rock star. And this woman is crying in the audience and he goes, wherever you go, there you are. And people thought it was a joke, but it actually comes from Buddhism. Wherever you go, there you are. And people go on these treks because they're out of a relationship or they lost their job and they decide, I'm going to go find myself. And so I've found in my travels that, and it's great to travel. And again, I know I sound like I'm always very cynical and I'm not a cynical person, I don't think. Am I, Julia? But you know, people do these things. They go traveling to kind of try to find themselves. And I've seen a lot of people that develop severe depression and anxiety on international trips, especially when you put them into a dangerous environment where suddenly there's an avalanche or they're in a storm and they're stuck in a tent for 5 days. And, you know, people go bonkers. So that's what I'm saying is that having sedatives, I used to, when I was young and stupid, I used to carry Haldol, you know, major sedatives that are used for, you know, schizophrenic patients and such. Those have a myriad of side effects. I didn't do that later in my career, but carrying something like Xanax, which is just a mild sedative, benzodiazepine, your psychiatry department will tell you that they would take this or that instead, and that's fine. But for people that are getting really anxious on board an airplane during severe turbulence, during an evacuation, they've got a broken leg, you've given them some pain medicine, but they're still really anxious. It's nice to be able to give people sedatives.
That makes sense, definitely. And you kind of touched on this a little bit, but I did want to ask it. Has it gotten harder taking narcotics for expeditions with the tighter prescription regulations that have been implemented recently over the past few years?
Yeah, absolutely. And I'm glad that I'm not doing it these days. I mean, I have to be honest with you all. I've retired as an expedition doctor. Right now, I'm teaching flying and teaching, I'm teaching medicine, but I'm not practicing emergency medicine right now. So I feel like I got out at a good time, but a couple things is I hate to chart. It was my undoing in medicine. I hate medical records. And I always thought wilderness medicine offered me the opportunity to go and write really crappy notes because, you know, it was just in a notebook at some little clinic or something. But you better believe the only time that I would write very thorough notes were when I was giving narcs. And you better believe that, let's say I'm looking at Julio's smiling face there. So let's say Julio is a patient on a trip and I don't know him. And he comes to me and he has some kind of an orthopedic injury and I'm treating him with narcotics. That's one time where I would put into a notebook, certainly a complete note on my assessment and my treatment, my reasons for using narcotic, and I would get Julio's address and phone number, et cetera, et cetera, et cetera. And then this is silly, and this is not what you should be learning. This is just how I did it. And I mean this. There's a difference between how one should do it, working with the DEA, et cetera, and how I did it in my career. But I would literally get narcotics from friends that would write scripts, and I would come back into the emergency room and I would say to the nurse, I've got all this morphine or whatever it was in those days. Can you waste it? And they would say, where did you get that? And I would say, it doesn't matter. I just want you to waste it and I want you to record it. And they go, fine. And they'd waste these narcs and they'd put in the back, in those days, binders. With just this note that they wasted the medicine. And I always felt like, let's say the DEA came after me. Well, they'd know that I'm Howard Donner and I was on this trip and I have a record of the patient, their injury, their phone number, their address, and I have a history of wasting the medicine I didn't use when I came back. It was hard for me to fathom that I was going to go to prison for 40 years. But in the modern era, I can't give you advice.
I would definitely. You have to protect yourself or you're going to end up like Shilpi.
She looks a little shifty.
We're good. We're clear. I told you I'm a medical student. Nothing is my fault. At least not yet, anyways.
All right. So I think we have time for maybe like one or two more. This is a really random one, but I think it's really interesting. What is your base weight on an average high altitude expedition?
Your base
Weight was a question, unless they.
Like your pack weight.
What?
Mm-hmm.
What does all my gear weigh?
Yeah.
So impossible, good question, super interesting question, impossible to answer. For example, let's say when I worked on Denali, I was a cheater. We would usually carry a sled. We called them pigs. So we would always pull a sled. And most climbers up there have sleds with maybe 60 pounds of gear in them. I would have about 30 or 40 pounds of gear in my sled because, don't tell anybody, because the Park Service would fly up some of my gear up to the 14,000 rescue station. And in my pack, most climbers are carrying 40, 45, 50 pound packs, and I'd be carrying 30 or 35 pounds. So it just depends. On all the expeditions I've ever gone on, I've always carried a lot of my own gear, but there have always also been porters carrying gear. So it just depends. You know, I was on a winter ski mountaineering trip a week ago. Carried obviously all my own gear. I didn't bring porters. I carried a very small medical kit. So, you know, my pack was very light and it was probably 45 pounds, which might seem heavy to a through hiker, but for a winter trip, that's not heavy. And I
Interesting.
and I guided for many years where I was carrying ropes and ice tools and all sorts of anchors, pickets and dead men. And so my pack would sometimes wear dead men or types of snow anchors, flukes. And so my pack would weigh, 60 pounds because I was carrying climbing gear. So it's one of those questions. It's a good question, but there's no answer.
All right, that's perfectly fine. It was a good answer either way. But I think with that, we're going to wrap it up. So thank you, Dr. Donner, for coming. I'm going to hand it over to Katrina just for some closing remarks. And after that, we will be done.
All right. Hey, for all of you, and I don't know all of you, but thanks for inviting me. And for everybody that weathered this talk, it was nice talking with you. I wish I could have met y'all in person. And again, special shout out to my friend Julio, and we'll see you next time.
Great. Thank you so much, Dr. Donner, for joining us. Thank you to the audience for joining us, and we'll see everyone next week, I believe at the same time, for another lecture. Thank you, and have a good night.
Night.
Thanks for coming, everyone. Thank you, Dr. Donner. Everyone, enjoy your night and see you guys next week for Airspace Medicine. Woo-hoo. All right. Bye.